Welcome to Natra Farm.
Magandang araw!
Welcome to Natra Farm.
Here in Natra Farm, we believe the real difference is made by people. And I am honored to be a part of this team of loyal and dedicated professionals with unwavering commitment to improve healthcare through quality products, sincere service, and a reliable partnership. Welcome to Natra Farm.
Oh, we have a guest. Good morning.
Good morning po.
Maayong aga sa imo.
Hi po! Hello po!
Maya paabak.
Magandang araw po!
Maupay na aga.
Our people are the Natra Farm advantage. You and your patients are at the heart of what we do.
Good evening, doctors. I am Hannah of Natra Farm, North Mindanao District Manager. Natra Farm has been your partner in your medical practice. And on our 30th year, we would like to invite you on August 27, 6 to 6:30 p.m. via Zoom for the launching of our new platform that can help both you and your patients, especially at this time of pandemic. We hope that you can join us in this one-time event. Doctors, the link is in the chat box, but we will also be sending you through Facebook Messenger and through text messages the invitation link. So thank you again, doctors, and good evening.
A pleasant evening to everyone in this webinar. I am Dr. Cindy Canceko Llego, the Secretary of the PPS North Central Mindanao Chapter. To begin our program, let us now place ourselves in God's presence as we view our invocation to be followed by the national anthem and our PPS hymn.
Mga kababayan, ang pambansang awit ng Pilipinas.
Let us now welcome our President of the PPS North Central Mindanao Chapter, Dr. Amelita Maria Hamoy, for our opening remarks.
Doc, nakamute ka?
Good evening, colleagues and friends. Welcome to our second webinar series of the PPS North Central Mindanao. In line with our celebration of the Breastfeeding Month, the CPD Committee brings you this webinar. Tonight's discussion will allay your fears and boost your management of your newborn patients in this time of the COVID pandemic. I thank you for attending this webinar and hope you enjoy our lecture. Good night.
Thank you, Dr. Hamoy. I'm happy to announce again that we have a good attendance for tonight's webinar. So far, we have more than 140 attendees. So without further ado, may I now introduce our moderator for tonight, the most handsome neonatologist practicing in Butuan City, Dr. Dean Angelo Dimaano.
Thank you for the kind introduction, Dr. Cindy. Good evening, doctors. Are you all excited for this lecture?
Yes.
Well, personally, I am excited for this lecture. You know why? Because I have reservations and fears when making rounds, seeing patients in the clinic, or catching a baby at the delivery room. Kung meron lang sanang telemedicine or telecatch, well, sana. Okay? Our speaker tonight is a graduate of medicine at Xavier University. She had her pediatrics residency and neonatology fellowship at UPPGH. She is an active consultant at Maria Reina Hospital and Northern Mindanao Medical Center. She's the co-convener of both the National and Medical EINC program from WHO. She is a member of the Board of Trustees, PPS NCM chapter. She is the head of advocacy for breastfeeding. She is a consultant of health and nutrition section of the UNICEF. She is a member of the Board of Trustees, Human Milk Banking Association of the Philippines. She is also the training officers of the Pediatric Residency Program at Maria Reina Hospital. Without further ado, let us all welcome Dr. Jessamine Sareno.
Hi, thank you, Dean, for the kind
Good evening,
introduction.
Doktora. Ready na po kayo?
Yes po. All right. So, okay. So, thank you for the introduction, Dean. Good evening, everyone. I would like to thank PPS NCM for inviting me to speak before you all today, and for NatraFarm for making this possible. Originally, the request of our Madam President and Vice President was to talk on breastfeeding because August is breastfeeding month. But I chose to talk about this big topic on the total newborn care in this COVID time because of the anxieties brought about by the pandemic and the fears of newborn transmission have actually influenced a change in practices of the pediatricians. It has impacted negatively a lot on the breastfeeding and rooming in rates of the hospitals, and eventually on newborn health outcomes brought about not by COVID itself, but by infants not getting the protection of breast milk, most especially in this pandemic. So these are the topics I desire to cover, hopefully in 1 hour tonight, based on the best available information in literature. In this time of uncertainty, health professionals need clear, practical guidance. So I hope this lecture can guide you in terms of decision-making in neonatal resuscitation, breastfeeding, and how to sustain the Unang Yaka program in your individual hospitals. This is my disclosure statement. My vested interest here only is that I am connected with Kalusugan ng Mag-ina Incorporated, which is the national NGO contracted by WHO Philippines to help DOH implement the Unang Yaka program in the hospital starting 2009. So it would be sad if the EINC program will be compromised because of unestablished but understandable fears on COVID. So that all of us will be on the same page, let's lay out first some operational definition. So what is a confirmed COVID-19 newborn? It is a newborn whose respiratory tract or blood specimens tested by RT-PCR are positive for 2019 nCoV nucleic acid, or the virus gene sequencing is highly homologous to that of the known 2019 nCoV specimen. What are the accepted suspected cases of COVID-19 newborn? 3 scenarios related with cluster outbreak or exposure to relatives. Number 2, maternal infection 14 days before delivery and 28 days after delivery. And a newborn presenting with neonatal lymphopenia and typical chest imaging findings. In terms of onset, when we say early onset, it occurs at the first week of life, and late onset occurs at 1 to 3 weeks of life. So what we know and we don't know so far. So globally, as of August 18 to 16 p.m. yesterday, there are already 21 million confirmed cases around the world, with the Southeast Asia contributing 3.2 million of this, and the Philippines as the highest contributor from Southeast Asia. The true incidence of COVID in children is not known due to the lack of widespread testing. But the latest data in the US as of August 3, 2020, there are only 7.3% of all cases in the US were newborns that were reported to CDC. Okay, so what we know so far, what I have read in the literature so far, neonatal COVID-19 disease is uncommon. The COVID infections in neonates are mostly asymptomatic. The health outcomes in neonates are actually favorable in pediatrics in general, and vertical transmission is not established. Separation of infants does not offer significant protection, and breast milk is not a transmission vehicle of infection. So based on the growing evidence on COVID and the epidemiologic data available, these are what we know so far. And I would be citing some studies and reports along the way to reassure you further that COVID is more or less kinder to our newborns. Okay? So we all know the modes of transmission. The most confirmed modes of transmission are usually droplet and contact transmission with infected mother, relatives, and healthcare staff. Droplet transmission through fomites in the immediate environment surrounding the mother. Airborne transmission via aerosol generating procedures and support treatments. When we say aerosol generating procedures, this includes the bag mask ventilation, endotracheal intubation, extubation, tracheostomy, tracheal suctioning, nasal cannula oxygen at flow greater than 2 liters per minute per kilo, the CPAP, the BiPAP, and the LISA. LISA is less invasive surfactant administration, where we put directly into the throat, not intubated. The patient is not intubated. And then nebulization and the high frequency oscillation ventilation. Support treatments that are AGP also is the open tracheal suctioning. So what is recommended is actually inline suctioning. I'm gonna show you later a photo on it. And even the act of CPR, chest compression, is an aerosol generating procedure. Nebulization is quite controversial because some studies show that argue that the aerosol in nebulization is not patient-derived, but some studies argue that some viral particles from the newborn can be mixed in the aerosol. So might as well avoid it. Okay, so here, back to my modes of transmission. It is these last two modes of possible transmission that have created understandable uneasiness among pediatricians and most especially neonatologists. I have to admit, like Dean, during the early course of the pandemic, March to April, my unang yakap practices wavered a little, and I did occasional temporary separation, especially if mother had a suspicious cough history. However, as the months go on, as the evidence of non-transmission of the virus via vertical and breastfeeding routes are emerging, and this evidence are actually leaning towards non-transmission, my anxiety dissipated, and I hope yours too after this lecture. Okay, so don't be intimidated. I just merged all the data available, local data. The Philippine Society of Newborn Medicine collated data from 22 hospitals across the country to have a baseline COVID data on newborns. As of June 2020, we only had 52 COVID positive newborns. I don't want to overwhelm you with the numbers, so I would just summarize key points from this available local data I have computed already. So 70% of the COVID positive newborns, both inborn and outborn, had non-COVID mothers. And 65% of the COVID inborn newborns had non-COVID mothers. And only 0.3% of COVID positive newborns had COVID positive mothers. So it's really a very small percentage to be conclusive. And some of these newborns have testing issues. We will be discussing neonatal testing later, but please note ahead that the COVID positive newborns here had oropharyngeal swabs done in the inborn population, had oropharyngeal swabs done, and most were done beyond 48 hours of life. So this would lead us to wonder how many of these positive COVID newborns got the infection postnatally, perinatally, through the actual delivery and through relatives and possibly healthcare staff. Those who were positive, if you can see, had favorable outcomes with no mortalities among newborns, among the inborn population. In the outborn population, we will zero in on the 0 to 24 hours of life. 4 were admitted. There's only 1 death among these 4 who presented symptoms in which nosocomial pneumonia was considered. Next, for those who had severe symptoms here, take note their mothers were negative for COVID. So thus, in general, definite conclusions on vertical transmission cannot really be established. In the literature, if you have read, there were recent reports of elevated COVID-19 IgM levels in 3 newborn infants, which have raised concerns about vertical transmission. But on confirmation by RT-PCR, none of these neonates were positive. In another report, 3 out of 11 placental swabs of COVID-positive women have detected SARS-CoV-2. Other issue in the report, the origin is unclear, given the mixing of maternal and fetal fluid and tissues. Source may be from maternal blood, amniotic fluid, or fetal membranes. For those vaginally delivered, vaginal secretions is also a possible source. In our local data, in PGH, the largest referral center for COVID, in May 2020, the OB-PGH department had 53 positive maternal COVID-19, and all of these have no maternal infant transmission documented. The latest data from PGH census as of July 2020, 108 babies were born to COVID-positive mothers. But out of this 108, only 2 were positive. The first one is the one presented in the virtual grand rounds 2 weeks ago, if you remember. And what the course said, that they got the sample by endotracheal aspirate and was performed at the 30th hour of life. And the other one who was positive was full term and test done beyond 48 hours. In northern Mindanao, going more local, in NMMC, no recorded COVID confirmed mother and newborn. And in Amaypakpak, there were 2 COVID positive mothers, but both infants were negative. So I would like to thank Dr. Villapanye and Dr. Ish Mapandi, our colleague, for this information. All right, so what can possibly explain the absence or very rare chance of vertical transmission from an infected mother? One strong explanation pertains to the entry or non-entry of the virus in the maternal-fetal interface. For the virus to gain entry into the fetal interface of the placenta, 2 receptors are required to be co-expressed in the surface. The ACE2 receptor and the TMPRSS2, which is a protease, no? It's a serine protease. Its role is to prime this S protein for the protein priming for the viral particle to enter into the surface. Okay, so don't be intimidated again with this. Look at the figures here. I would just like to prime you. The color green are the expression of ACE2 receptors in the placental tissue. Blue is TMPRSS2. And if there is co-expression, it would be orange. So if you look at the left plot, there is a polarized or clustered expression of ACE2 in the stromal side away from the maternal blood. And there is pronounced absence or near absence of the MPRSS2 expression in the trophoblast and villus endothelium. So if you can see this orange co-expression, this is in the stromal area away from the maternal blood or the endothelial cells. In a recent study just this August, they studied 19 actual placentas of COVID-19, and the results are similar, which boost further the fact that congenital infection appears to be exceptionally rare despite maternal infection. We also have to note that placental infection does not always equate with vertical transmission. Then we should not forget also the chance of perinatal infection. During vaginal delivery, maternal feces can be a source of infection. 30% of newborns were positive for RT-PCR in their rectal swabs. And then there's also exposure to maternal respiratory secretions after birth. So to really confirm SARS-CoV-2 is really nasopharyngeal, nasal or throat swab positive PCR within the first week of life. So let's talk about neonatal testing, because we should always consider sampling and timing in the interpretation of neonatal results. Recommended testing will always be RT-PCR, is the standard, and the recommended samples will be nasopharyngeal, from the nasopharynx, oropharynx, and the nasal swab. Serologic testing is not recommended for acute infection in neonates. In areas with limited testing capacity like us, testing should be prioritized for neonates with signs really suggestive of COVID-19 and those neonates with exposure to high levels of care or expected prolonged hospitalization because mothers are maybe delivered through cesarean section. When to test? When the baby is symptomatic, asymptomatic neonates of suspected confirmed COVID mothers, they should be tested at 24 hours. If negative, repeat at 48 hours of age. Asymptomatic neonates to be discharged, expected to be discharged less than 48 hours, a single test at 24 to 48 hours of life. So the test should be within 24 to 48 hours of life. There is currently a knowledge gap on the optimal timing of testing after birth. If too early testing, you can have a false positive. They may be contaminated by SARS-CoV-2 RNA in maternal fluids, but you can also have false negative because RNA virus may not yet be detectable immediately after exposure. So this is the knowledge gap currently in neonatal testing. Let's go to breast milk transmission. The detection of SARS-CoV-2 in human breast milk were documented in a mother, but take note, the sample size is 2 mothers. And it's only positive in only 1 mother. And in this study of Lancet, the questions raised were about the disinfection, the sterility of pumps and tubes, and the processing of the milk. What is the better data? Is this data by WHO, which is the latest data in June 2020. They did a living systematic review between 4 databases, Cochrane, WHO Medline, and the WSCC Web of Science Core Collection databases. And they tested 46 COVID-19 positive mothers and with their breast milk samples tested for COVID-19. And they found out only 3 samples tested positive for viral particles. The one infant tested positive for COVID, but infant feeding practices were not reported, and it was unclear through which route or source the infant became infected. Is it from breast milk or droplet from a close contact? The 2 other infants tested negative for COVID-19. So from this big data, breast milk is still not considered a transmission vehicle. So SARS-CoV-2 pandemic requires the promotion of breastfeeding with proper health and hygiene approach to limit contagion by air and by contact. So still breastfeed with the mother wearing face mask, hand washing before and after contact of the infant, and also breast hygiene, and then cough etiquette. So that's the best way to limit contagion. So why is there a need to promote breastfeeding? Because of the evidence of significant secretory IgA immune response in human milk following recovery from COVID-19, which was found in 12 out of 15 breast milk samples from mothers infected with COVID-19. There are also antibodies in breast milk and IgG in neonatal serum. So antibodies were also detected in the breast milk, with also an IgG in the serum detected in 1.5-month-old infant. All right. So this is beautiful data, FYI, in breast milk. We all know lactoferrin is a protective factor in breast milk, which is really a key component in the innate response to RSV, NEC, and sepsis in neonates. But because of lactoferrin in general can actually prevent viral infections by interacting with heparin sulfate glycosaminoglycan cell receptors, which allows the first anchoring site in the first phase of virus infection. After anchoring, the viruses then accumulate on the cell surface, which recognize more viral specific receptors, which includes the ACE2 receptor. Remember the ACE2 receptor? This is the receptor which SARS-CoV can enter human cells. So lactoferrin actually prevents not the ACE2 receptor binding, but the preliminary contact between SARS-CoV and host cells by blocking the interaction of the spike viral protein and the glycosaminoglycan cell receptor. So assuming a newborn is really infected with COVID, how do they present? Newborns present with non-specific symptoms. So not all takipnik newborns COVID agad. No? So in a European study, they identified 25 cases of newborns with SARS-CoV. And the most common is actually dyspnea or shortness of breath. There's no cough, no, 0% cough presentation. Newborns don't cough too much. And then fever, feeding intolerance, and abnormal radiologic findings. So this is in Europe. Let's go local. Please take note of the last column. This is our local data, the Philippine data, and these are the data from other countries or other studies. So China, and this one is US. So if you can see, most are really asymptomatic. There is difficulty of breathing, fever, poor suck, vomiting, diarrhea, and then there is bloating and abdominal distension, and some present with apnea. So in our country, more of difficulty of breathing, and really most are really asymptomatic. Okay. The good news is that the outcomes of our newborns are really favorable. Out of the 26 newborns in our setting, 25 survived and only 1 died, mostly due to prematurity complications. All right, so going clinical, what are the questions or anxieties of the neonatal care provider? So the questions in our mind will be, what is our course of action in the delivery room of an infant born to a COVID mom? How should we healthcare workers protect ourselves? What is the respiratory management of a newborn in distress? And if the patient deteriorates, what procedures are allowed? And should EINC protocol be continued in this time of COVID? To separate or not? To breastfeed or not? Okay, so I know we had these questions when the pandemic broke out. No? So, and what adds to our anxiety is that we cannot simply extrapolate adult recommendations to neonates. So this is a graphical presentation of the ideal DR setting. So if your hospital is capable, why not? No. So if mother is positive, mothers must wear mask for source containment. Technically, the DR should be in a negative pressure room is preferred. No. And then if not, then that we have to make do. And then we healthcare workers should wear full PPE. And again, a virtual interaction capacity with partner for emotional support. And the OB or the one who delivers the baby should have full PAPR N95 mask if aerosolization procedures are likely. Delayed cord clamping is acceptable. There should be a minimal number of providers in the room to avoid crowding, as well as to conserve PPE. On the other hand, on the PDS side, there should be a transport. The newborn should be transported. If the baby will be transported to NICU, he should be transported in an isolate, not in an open crib. Okay, resuscitation equipment should be ready. Additional providers outside the room for backup. So hindi lahat dapat in the room. No, so let's conserve PPE as well as avoid crowding. Okay. All right, resuscitation will still follow the NRPH algorithm guidelines set by the Philippine Society of Newborn Medicine, but this time with COVID precautions. Okay, so what are these COVID precautions? So another graphical representation. Baby should be in an incubator with hood elevated with heating source. And there should be a physical barrier or curtain if resuscitation is performed in the same room with the mother, but it should be more than 6 feet or 2 meters away. Okay? So airborne precautions for aerosol generating procedures such as intubation is still full PPE. Okay, and then again, limited number of providers in the resuscitation room with the most experienced resuscitator involved in the team. All right. So when you resuscitate, there's a likelihood that aerosols and there is also potential need to perform newborn resuscitation. So again, complete PPE. And your ambu bag and ventilator should include a bacterial or viral filter in place. So I know you have this pre-COVID, dinededman natin to. So pre-COVID, parang kebs lang to. But this time, this one takes a major role in resuscitation now. So when there is a need to do PPV, we know PPV is an aerosol generating procedure. But sometimes we have to, because guideline says within the golden minute, within 1 minute, we should be providing ventilation to the newborn. So our ambu bag should have a viral filter attached already. And this is a improvised tubing with a suction inside, and again attached to another viral filter for inline suctioning. So with open suctioning is not allowed to avoid, because it's an AGP procedure also. So the setup would be the ambu bag with the viral filter here and the face mask, and this one attached again to another viral filter with the tubing containing the suction tubing for suctioning the infant directly into the trachea. So we can improvise. We are good naman there. Tayong lahat Pinoy. We are good in resourcefulness. Okay? So the question now is aerosol box. Talagang everybody was so gaga in getting one in the first few months of the pandemic. No? So is it really worth it? So this is an interesting report of the New England Journal of Medicine. The report, the investigator did a comparative study in using aerosol box, PPE only, and PPE plus the aerosol box. They had a 10 ml fluorescent dye in a balloon inserted into the hypopharynx of a mannequin with a tubing inside with compressed air flowing to burst the balloon. Then they illuminate a UV light to visualize the spreading of the fluorescent dye once the balloon bursted. So the results show that if PPE only, there were the fluorescent dye as the viral particles were spread all over the gown, the gloves, the face mask, the eye shield, the hair, the neck, ears, and shoes, and the floor 1 meter away from the bed, and the monitor more than 2 meters away. But in the PPE plus the aerosol box, so pasok doon, only the inner surface of the box, the gloves, and the gowned forearms inside the portholes showed the spreading of the dye. So in conclusion, barrier enclosure provided additional protection and could be considered an adjunct to the COVID management in the DR. But there is a caveat. Now, the box, and I've experienced this one, the box restricted hand movement and would require training before use in COVID management. We operators should be ready to abandon the use of the box should airway management prove difficult. So in my experience, I really dropped the box. I really abandoned the box twice during resuscitation. More of vision problem. No? More of the vision problem. So it should be well designed. It's quite helpful theoretically if you look at the report. Okay, so if the baby needs to be admitted, where? So for infants requiring neonatal intensive care, the ideal is to admit to a single patient room with a potential for negative room pressure. Infants should be maintained at least 6 feet apart or placed in air temperature controlled isolate. For infants not requiring NICU, should not be admitted to the main NICU with other sick infants, just for isolation purposes only. Okay, so that's from AAP and CDC, right? So looking at this slide, look at the footnote. The data is from the AAP COVID-19 initial newborn guidance on last May 2020. So this is an initial newborn guidance, no? So we guided para as to guide the practitioners. So for the DR staff, we all know this one, wears full PPE, standby to conserve PPE, isolate. This is what I want you to focus, the non-separation. Their recommendation at the start, because of still with the lack, maybe no strong data yet, they recommended temporary isolation in a separate isolation room. But this should be discussed with the mother. But if the mother wishes to be with the baby and will not be separated, or if non-separation is unavoidable due to facility limitations, newborn should be kept more than 6 feet or 2 meters away from the mother. A curtain or an isolate to facilitate separation in between feedings. And during feedings, face mask, hand washing, cough etiquette before and after contact with baby. Okay? So this was an initial guidance from AAP. Because of this guidelines or recommendation, the Philippine Society of Newborn Medicine were very cautious in sending out our recommendation. So in stable newborns that did not be admitted, the question remains, should we room in? So the guidelines of PSNBM, this is part of the whole algorithm of PSNBM, which I did not post kasi baka ma-intimidate ulit kayo. But they were very cautious. They have this, we are very cautious. PSNBM show the shared decision principle. When we say shared decision, it is room in with mother with droplet and contact precautions, or separate temporarily until baby's test results are available. And then breastfeed per demand or give a express mother's own milk, MOM, or pasteurized breast milk if available. So shared decision means the mother is being counseled regarding the risk and benefits of skin-to-skin care and separation, the consequences of not initiating breastfeeding at time of birth or suspending breastfeeding temporarily, and the risk of exposure to both the baby and healthcare workers, and is important before delivery. And after all this counseling, the mother chooses her options dapat before delivery to guide the actions of the pediatrician. So because of this is a summary. Take note again of the month. It's May 2020. Basically, if stable mother, the non-separation and breastfeeding is shared decision. Is early rooming in with the mother or separate temporarily. And then breastfeeding is again shared decision. Breastfeed baby with precautions or give express breast milk. But for unstable mother, the baby can be admitted in isolation, or infant may be discharged because the mother is still unstable. Infant may be discharged with a designated caregiver. And if the newborn himself is unstable, admit in NICU isolation. For breastfeeding, maintain the mother's milk supply if the mother intends to breastfeed. Express mother's own milk if feasible, or pasteurized breast milk. All right. So because of this recommendation, it is quite a challenge to sustain the EINC protocol in the hospital, especially in the skin-to-skin contact and the non-separation and breastfeeding protocol. So it's quite challenging, a lot of issues, a lot of fears. So that's why based on the AAP guidelines, so there was a pressure to isolate, but there's also a pressure to really promote breastfeeding because of its protective effects. Okay, so let's go first to non-separation. We all know non-separation allows the first breastfeed to be completed through the uninterrupted skin-to-skin contact. Non-separation may slow down, separation may slow down the readiness of the baby to breastfeed and may have other negative health impacts. Most importantly, early separation may increase contact with multiple health professionals who may be infected but asymptomatic. And separation can lead to crowded neonatal neonates, non-ideal nurse-patient ratio, and increased risk of infections and morbidities. So the question now, to separate or not to separate. One study showed that a baby tested positive at 36 hours of age despite being separated and received formula. The baby was stable apart from vomiting during the first formula feed. In another study, 3 COVID-infected newborns separated from the mothers still had COVID despite the separation and have acquired the virus from the family members. And more controversial is the 10 newborn infants in Romanian ward tested positive even though their mothers were negative, suggesting that they were infected by health professionals. So if you look at the source, criminal file opened, I think. So what is the message of this? The fact that some newborns have become infected after being separated from their mothers suggests that separation may not offer significant protection. So if you notice, I've been citing, taking note of the month, of the publication, of the recommendations, because breaking news, as of July 2020, AEP now approves rooming in with precautions. Why? Because of the emerging evidence, no? As pandemic months, as the months pass by, no? So data gathered from 1,500 mother-infant diets in the National Registry of Perinatal COVID-19 infection revealed that the likelihood of an RT-PCR test positive result was similar for infants who were separated from their mothers and those who were roomed in with mothers when infection prevention were used. So it's the same likelihood ratio, okay? So because of this, so I hope we will make revised guidelines also because of this emerging evidence and new recommendations of the AEP as well as CDC actually. I checked and they also recommend rooming in because of the evidence. Okay, now let's go to one of the components of unang yakap, the non-immediate cord clamping. There's actually no issue. All the groups, the big groups, WHO, ACOG, and AEP, stated that there is no reason why the infant should not have the benefits of delayed cord clamping and skin-to-skin contact. So there's highly unlikely to increase the risk of transmitting pathogens in delayed cord clamping. Okay, so breastfeeding newborns, I have shown data earlier that the studies have not detected the virus in breast milk. Okay, so in our clinical experience, there's pressure to separate newborns, and the eventual outcome sometimes is the use of formula instead of breastfeeding. So promoting breast milk feeding and supporting establishment of maternal milk supply may offer additional benefits to well and sick newborns. Okay, so for example, how to breastfeed sick infants of infected mom. You can do express breast milk after appropriate breast and hand hygiene. Okay, the uninfected caregivers can feed the infant, can feed the express breast milk to the infant. And breast pumps and components should be thoroughly cleaned in between pumping with disinfectant wipes and washing pump attachments with hot soapy water. Remember, virus particles can be in plastic from I think it was 3 to 4 days. Okay, so direct breastfeeding should comply with strict preventive precautions, mask and meticulous breast and hand hygiene. Okay, so we're almost done. WHO recommendation. WHO recommends that mothers with suspected or confirmed COVID-19 should be encouraged to initiate or continue to breastfeed. Mothers should be counseled that the benefits of breastfeeding substantially outweigh the potential risk for transmission. So WHO recommends continue breastfeeding, skin-to-skin contact, including kangaroo mother care, and especially establishing breastfeeding whether they or their infants have suspected or confirmed COVID. Okay, what are the other COVID protocols? How about NICU visitation of infected mothers or caregivers? Again, this is the latest guidelines. The last guidelines of AEP dapat negative RT-PCR, but emerging evidence show na kahit 3 months na, you can still have a positive RT-PCR despite being asymptomatic. So now, the latest guideline is people who are immunocompetent are not considered infectious if symptoms have improved, are febrile for 24 hours without use of antipyretics, and at least 10 days have passed since symptoms appeared, or since positive result for the asymptomatics. For those immunocompromised and critically ill, it should be extended to 20 days before they can do NICU visitation. Other COVID protocols, ENBS and hearing screen should take place as usual. Please restrict performing tests and procedures post-discharge. For example, BCG only on every Saturday. So you will allow newborns to go back to the hospital for a BCG because you only open one vial for a lot of babies. So please avoid that and schedule to the echo. If you can do to the echo or cranial ultrasound while still admitted, then do it to avoid hospital exposure again. And for neonatal discharge, always aim for early discharge. Consider tele-video consultation for follow-up. So right now, for me, I don't schedule follow-up just for follow-up. No? So if we can do teleconsultation and can settle the issues through teleconsulting, then fine, okay? Then advise the high-risk group, like preterms, for example, on infection control and preventive intervention. Okay, other issues questions that you might ask. Sorry. This one, is this helpful? This plastic barrier during delivery to ensure unang yakap can be done. I think this was really favorable in our society because we really want unang yakap to be done. But infectious-wise, on the IDS perspective, it's actually the cleanliness or the hygiene of the plastic. So, and I agree eventually that there should be really meticulous care of the plastic, because after a few days use of the barrier, medyo hindi na siya masyadong clean, no? So, you can do this one to allow unang yakap done, but there should be disinfection or routine cleaning of the barrier enclosure. And we all know the PSNBM statement on wearing of face shields for newborns, all less than 2 years old. We recommend not using face shields because of carbon dioxide retention and suffocation. All right, discharging newborns, discharge based on the normal criteria that you usually use based on the discharge criteria. And infants determined to be infected but asymptomatic may be discharged on a case-by-case basis with appropriate precautions. Frequent OPD follow-up through 14 days after birth. And again, the standard hygiene, protection, and uninfected individuals more than 60 years old and those with comorbid conditions should not provide care to these infants. Okay, so ang mga lolo and lola dyan should not be allowed to take care of these infants. Okay, so infants with negative SARS-CoV but mother is positive, discharged to the care of a designated healthy caregiver. So for example, the mother is still in the hospital because of COVID. No? If the mother wishes to be not separated, mother should maintain a distance of at least 6 feet, and when in closer proximity to the neonate, should use a mask and hand hygiene pa rin. Other caregivers, example, contact tracing in the home who remain under observation should use again proper respiratory precautions when taking care of the newborn and should be within 6 feet of the newborn if not handling the newborn. Okay, so take-home points. Again, I would review same take-home points. Not common, mostly asymptomatic, favorable outcome, vertical and breast milk transmission is not documented well, and separation of infants does not offer protection. Additional take-home points in infants, while the consequence in infants, the risk of COVID infection is low, while the consequences of not breastfeeding and separation between mother and child can be significant. Pneumonia, diarrhea, because of the lack of breast milk protection. Health outcomes, favorable. If not, then more common causes of neonatal morbidity should be considered. Remember, those COVID-positive moms may have hypoxia, and so if the baby comes out toxic, sometimes it's not due to COVID, but due to the maternal hypoxia, the consequences of the maternal hypoxia to the perfusion. And then, last two, early essential newborn care should still continue. Positive health outcomes are more certain than the uncertain chance of transmission. And speaking as neonatologists, we can only provide guidance based on available data and not yet fixed recommendations as new evidence are emerging based on newer studies. So what we don't know, we know now may not be true later. So food for thought from a mother who had COVID on her 3rd trimester of pregnancy, a doctor, we should wise counsel in the face of unclear risk requires not fixed recommendations, but an ability to sit comfortably with uncertainty and mold it into something therapeutic for the patient before us. As a physician, acknowledging it can be the best way to help parents make informed decisions that are right for themselves and for their infants. So thank you and be COVID safe, everyone.
Thank you very much, Jess, for that very informative lecture. It answered a lot of questions and anxieties in my mind, as I think it would have done also for the other participants in this webinar. Just a reminder for all of our attendees, we would like to remind everyone to stay until the end of the program so that you can access the CPD quiz and get your certificate at the end of the program. And during the open forum, you may type your questions in the Q&A box located on your Zoom panel. For questions about your CPD certificate, if you'll have trouble later on, please email us at ppsncm.cpd2020@gmail.com. So now I'd like to give the floor back to Dr. Dimaano for the Q&A.
Doc, naka-mute po kayo.
Hindi naman.
Yan. Thank you for that wonderful lecture, Doktora. To be honest with you, ang dami kong na-screenshot. Kompleto pong lecture nyo. How about you, doctors? Ready na ba kayo bumalik ng hospital at mag-catch? But before that, let's proceed with the Q&A muna. Okay? So if you have question, just type it in the chat box. So, Doktora, meron ba tayong first questions? First question natin. Okay. Okay, we have a first question. Doktora, please listen. Ito po, medyo popular tong question yan. Is it okay to use UV light to sterilize breast pump?
Okay. So I know this about UV disinfection. When you have UV disinfection, like in any in disinfecting a room, you have to avoid the 4 P's: plastic, plants, photography, people. Okay, so it also applies to UV disinfection. I don't recommend UV disinfecting the UV disinfection of the pumps, because one of the no in UV disinfection is polypropylene plastic. So when you do UV disinfection, no to polypropylene plastics.
Well, thank you for that answer, Doctor. Very popular po ang UV light, especially 59S. Ang daming bumibili, no? To be honest with you, I have excess UV sterilizer at home. Okay? Next question. What about the follow-up vaccination of the newborn? When is the best time? Or do we still follow the routine schedule? Okay? Medyo popular question po to sa mga mommies natin.
Okay. So there's actually no recommendations set by AAP regarding vaccinations. But in general, the recommendation is to really avoid recurrent exposure to the hospital. So one of the good practice is to really, if you can do vaccination together, like for example, instead of 6-in-1 and Rota now, then 2 weeks later, because it's 2 months already, you do a PCV vaccination. Why not do it together in one setting? Okay, so I think we can do that one in our practice, really cluster the vaccination so that exposure or going back to the hospital is not repeated. Nakakapagod kaya sa triage. Tinatriage ka pa. So, but it's more on the avoiding recurrent exposure to hospital. So we can cluster, we can have 2 injections in one setting, like Hexa and the 6-in-1 and the PCV during one setting. We can do that. And then the rotavirus. Okay. But there are no fixed recommendations. There's no change in practice.
Okay. Doctor, how about sa mga health center? Can you advise something about the social distancing? Kasi there are mothers who are afraid to go to the health center kasi usually crowded.
Okay, so
ano kayo magandang suggestion?
I cannot contest with what the LGU will do about this, but I can only lobby for my patients. I really recommend them going to the health center, again, clustering the vaccinations that can be given to the patient, and then kung may pila, avoid exposing first the infant, and then that's when it's their time to really vaccinate. Then for their time to vaccinate, then tsaka sila pupunta. In some centers, very good centers, they do house vaccinations in their area. Kaya I commend those health centers who do na lang the house to house the vaccination in their barangay. No, so that can be one of the suggestions.
Nako.
Also.
Actually, in Manila, doctor, there are my mga batchmates, naka-complete PP, they do house call.
Yeah, they do. They do house drive-through vaccinations also. Some do drive-through vaccination.
vaccinations. Okay. We have another questions.
Disclaimer,
Do you have?
sorry.
Yes. Oh.
Disclaimer lang ha, the drive-through vaccination is not favored by IDS because of the cold chain issues.
Oh, thank you. So, another question, Doctora. Do you have some ideas where to get viral filter is for our PPD bags? Tama, PP. Pwede kaya yung mga N95, surgical masikat?
No. The bacterial viral filter for the ambu bags is usually really the one that I showed the picture. It's actually available. It's common. It's not actually rare to find a bacterial filter. Usually, when you purchase tubings, ventilator tubings, when you purchase the ventilator per se, they also provide the bacterial filter for this equipment. So you can have that. I forgot to mention bacterial filter, the one for the ambu bags is disposable. So wag pong reuse in another infant. Okay?
Wow. So far, wala pa tayong ibang question. So, Doctora, how about, you mentioned in your lecture earlier that the advisable is actually the negative air pressure. How about in our setting, okay lang bang air purifier as an alternative?
So as I mentioned
Kasi very
earlier,
popular nga ng mga air purifier.
so we make do actually, no? So sometimes we just we follow the guidelines. We can, if there's no negative pressure, then at least no aircon, turn off aircon, no if you can open the windows. Okay, so the air purifiers, I have no evidence. I have not read evidence on it. But they say it's helpful. But I'm sorry, I don't know anything. I don't know anything on the efficacy of air purifiers. No.
Yeah. Okay. So we have another question, Doctora. I think if you have mentioned this earlier, we have a COVID positive mother. The baby test showed negative, but was the negative less than 24 hours of life. Should we repeat the PCR test? Baby is already more than 48 hours asymptomatic.
Okay, so the protocol says that if early testing was done, we should do 48, we should repeat it at 48 hours of life. If the baby, if the RT-PCR will be done later, then we cannot conclude anymore that it's a vertical transmission because you have other forms of exposure for the baby. It can be postnatally already. It can be through the healthcare staff. So that's why, as I've told you earlier, there is a knowledge gap on the optimal timing. But currently, the recommendation is 24 to 48 hours. And if negative in the first 24 hours, you should repeat at 48 hours of life. If the baby is asymptomatic and you need to discharge, then you need to do a single test at between 24 to 48 hours of life. So beyond that, for your case, if the RT-PCR is done beyond ilang hours yun, beyond 48 hours of life, you should consider other
48
sources.
hours.
Yeah, you should consider other sources of infection. Okay, contact tracing na yan.
Okay. Doctor, I read somewhere that CRP daw pwede siya maka-help in predicting COVID. Do you suggest CRP? C-reactive protein test?
No. CRP,
No. Okay.
CRP in newborns, even pre-COVID, COVID or not, CRP is never an accurate and reliable test to diagnose infection. It is usually used in newborns to monitor response to therapy and everything. So CRP is never part of the guidelines in the test for COVID infection. So it can be an adjunct to other to other tests, but it should not be used alone to detect or to diagnose infection.
Yes. Okay. So, doctors, do you have a question? Or excited na talaga kayo bumalik sa hospital? Okay, so we have one more question, Doctora. Okay, so if a mother with confirmed or suspected COVID-19 is expressing her milk for her baby, are there extra measures needed when handling the breast milk pump, milk storage container, or feeding utensils?
Okay, so first and foremost, when the mother is about to pump, again, respiratory precautions, hand wash, and then breast hygiene first, and then using the pumps, the tubings, it should be it should be clean. It doesn't have to be a special like UV or something. It should just be clean with hot soapy water for before use of the pumps, not before using the pumps and the bottles for storage. And in terms of storage, you can still store them, the usual storage of breast milk. But again, those who will be storing or handling the bottle from pumping to storage to feeding should again be observing proper respiratory precautions. Okay, so again, it's really cleansing of the bottles is crucial because viral particles can still stick into the surfaces of the plastic.
Yes, okay. Actually, doctor, I have one patient, 3 beses daw niya hugasan ang kanya mga baby toys, mga baby equipment. Okay, we have another question. Actually, this is a nice question, doctora. In areas with documented local transmission, for newborns presenting with progressing pneumonia or develop pneumonia later during their hospitalization, should we test for COVID?
Okay, so there's a lot, very nice question, no? So actually, one of the criteria to accept newborns as a suspected case is those newborns where there are cluster outbreaks. So if you remember my slide, number 1, cluster outbreaks, no? So there's a local transmission in the area, and the next thing to consider, if the newborn is still admitted, but the NICU visitors, the one who's visiting the baby, no, so yung di ba locally transmitted in an area, and the mother is from there or the father is from there, and then visits the NICU to see the baby. So again, we cannot ignore the fact that you might also be as these visitors can be asymptomatic carriers because they are in a local high risk area. So it would be nice, no? It would be nice if you have the capacity to test the baby. Why not? Because as I said, there is a priority testing of newborns in an areas with limited testing capacity. One of the priority neonates to test are actually those with high cluster outbreaks na area.
Ang ganda sana, doktora, kung may mga televisitation sa NICU, no?
Yeah, oo nga eh.
So,
but we need to do PE.
Televisitation, telecatch. Okay? May mga questions pa ba tayo, doctors? O talagang ready na kayo bumalik ng hospital? Okay. So I think all the questions have been, Doc, ang konti lang ng tanong natin. Again, thank you for the wonderful lecture tonight. Very fruitful po. Okay? That's all for tonight. Back to you, Dr. Cindy.
Okay, maybe their questions in their mind had already been answered by the lecture. That's why we only had quite a few. But
yes, I agree,
now,
Doctora.
Yeah, it was quite an informative lecture and a very informative Q&A as well. We had very nice questions from those who dropped their questions in the Q&A box. So at this point, I would like to welcome our Vice President of the chapter, Dr. Therese Habay, for the closing remarks. Dr. Habay.
Okay, good evening. I will not make this long. It's getting late in the night. I would just like to thank several persons for making this activity a successful one. First of all, I would like to thank Dr. Sareno for accepting our invitation for the lecture. Thank you, Jessa, for a very enlightening lecture. Looking forward to be your committee chair for your shower party soon. To Dr. Dean Dimaano, thank you for acting as the moderator. To Cindy for being our Emcee, and to Natra Farm for all of the help and support and for providing this platform. Let me also thank the other CPD committee members working very hard behind the scenes, like Early Sanchez, Dr. Michael Te, and Dr. Jao Oliveros. And lastly, let me thank you all for taking time out to attend this activity. Hoping to see you once again on our pre-fiesta webinar, which will be on August 27. Good night and stay safe, everyone.
Thank you, Dr. Habay. The
Bye-bye.
link to the CPD quiz will now be posted on the chat box. Please just choose one of the 3 links provided. Click on the link and answer the 5 simple questions. After submitting your answers, check your email for your certificate as it will be automatically sent. The links will also be posted on our FB page. For questions about the CPD certificate, email us at ppsncm.cpd2020@gmail.com. So once again, the links are now in the chat box. Please just choose one of the 3 links and then check your email after you submit your answers for the quiz. So with that, I would like to thank everyone for attending our webinar tonight. Hope you learned a lot. And I also hope that we all keep safe and healthy. Good night, everyone.
Congrats, Doc.
Congratulations, Jess.
Congratulations.
Congrats sa inyo tanan.
Dili ra boring.
Nice kayo. Dagan mag-attend.
Congratulations, Doktora.
185. Hi, Ma'am Hana. Thanks,
Congrats, Doc.
PJ. Thanks, Ma'am Hana.
Tara,
you.
welcome
Sa
anytime.
Doktora.
Thank you, everybody.
September po, Doc.
September po, kita na
We'll see
punta.
you. Yep. Kuan man
Thank you, Doc.
in celebration pa rin sa
Bye-bye.
fiesta tong next
Ayun.
na ano, Doc, no? Next na na webinar?
September 20.
21,
Ito,
Doktora.
21?
21.
Yes, Doktora. 21. Yes, Doc.
Thank you kayo.
Doc,
Doc,
salamat
welcome, Doc.
po,
Thank you po, Doc.
Doktora.
Thank you.
Doktora
Doc,
Sareno,
congratulations.
congrats, Doc.
Salamat.
Bye,
Bye,
everyone.
Doktora. Good night.
Doc Sins.
Good night.
Bye, Doktora
Congratulations.
Sins.
Si Doc
Sige,
Dean ba?
bye-bye.
Nag-out na si Doc Dean, ma'am?
Naapa si Dr. Dean. Dr. Dean, congrats, Doc.
Page.
Po.
Nasa chat.
Yes.
Ala, di daw nila makitaan sa chat box.
Nila makita.
Naman
sa chat, Doc.
Kasi kita raw kita. Di daw sila kita.
To all panelists and attendees, Doc.
Oh. Naka-broadcast pa ba ta?
Yep. We're still live, Doc Clara. I will not end na lang, Doc, until hindi, wala naka, ang uman.
Disabled daw ang chat box. If,
Naman, Doc.
Dara to all panelists and attendees, Doktor, ang
May naka-access. Ma'am, tawagin daw sila Che, ma'am, kung makita ba nila.
Sige, sige. Makita daw, Page.
Makita man.
Naman, makita naman siya.
Yep, girisan ako actually, Doc.
Ha?
Girisan ako actually.
Ano man siya?